So just a kind of a thought-provoking question. So you've got a gentleman who's got active immunotherapy on board. He does end up getting 6 cycles of Xofigo and actually has a fairly nice response. His PSA, again, is still low, but he does have a reduction in his alkaline phosphatase. His use of opiates goes down after the 3rd dose. We know that radium-223 is an alpha emitter. It's a bone-targeting therapy. We know based upon Alsimca there is a survival benefit. We know that there seems to be less myelosuppression relative to the other drugs that we've used in the past, which were betas and gammas. Now the concept, and I guess this is more a philosophic question, given that it is a calcium mimetic agent and we really haven't done anything yet except for LHRH therapy to look at manipulating the androgen axis, do you concomitantly in your practice also administer any type of ABI or ENSO?
Well, we're doing a trial to look at that. And there's a randomized study that's randomized phase 2 that we're looking at radiographic endpoints of ENSA plus radium versus ABI plus radium versus radium. And there's also a larger randomized trial of ABI plus radium versus radium that's going on as a registration study. So I think people do it. There is no data to support that right now, but they do it off-label.
Yeah, I mean, I think realistically, a lot of people are using combinations, particularly when you get in a situation, had this same patient had more predominant lymphadenopathy over 3 centimeters or so. That's very tempting to say, well, let's add some ABI on there or enzalutamide. Either one, there's no, I mean, I'm not preferring one over the other. I'm just saying, I think realistically, it has been shown in marketing research that a lot of people are automatically using combinations.
I guess my concern is, and see if any of you agree, because I'm just kind of way out there at this point, is I worry a little bit, especially are we forcing the cells to mutate at a time where maybe we don't have to? I mean, right. we do know that there is treatment pressure selection and you do get mutations, and obviously we're going to hear more and more this week, I'm sure, on ARV7, and we do know that the use of ENSA and ABI can flip that. So again, it's sort of, when do you add, when do you combine?
So I thought you were going to go down a different pathway, which was you mentioned the fact that there's prolonged activation of the immune system with CYP-T, and you can find T memory cells in some situations 6 to 7 years after the initial administration of CYP-T. And we do know in melanoma there's something called the abscopal effect, where when you give radiation therapy, you enhance the immune system and allow cells to become more immunogenic. So my question would be, is there an abscopal effect with radium? And we're actually looking into some questions right now, and we're looking at different immune factors or parameters after people receive radium. My junior attending, Joe Kim at Yale, is looking at that particular question. So I think that that's going to be an interesting way of sequencing some of these drugs. And in fact, Chuck Drake's trial with ipilimumab, patients were radiated before they received the ipi in the bone. So this is actually another potential interaction.
So if a urologist was choosing an oral agent next after the Sipuleucel T, would you have any recommendations between the two and the issues or non-issues with steroids after Sipuleucel T?
Well, I would tend to choose the option that does not require steroids, which would be enzalutamide. Although, the product itself has not been affected by low-dose prednisone, so that's been looked at. So if somebody's on 10 milligrams of prednisone, it doesn't seem to affect the product parameters that are checked when the product gets sent back to the patient. But we don't know if a patient is on low-dose prednisone after receiving CYP-T, their CYP-T infusions, if that's going to have any effect on the efficacy of the immune system. I mean, don't forget, in many other diseases that are immune-based, we can get by with treating somebody with low-dose prednisone. for whatever it is, whether it's, polymyalgia rheumatica or whatever. And so it's definitely can be a very potent, it can have a very potent effect on the immune system. So if we don't have to use it, I'd rather not.
I think that the one thing about Eric Small's trial, where he gave prednisone abiraterone and prednisone at the beginning of sipulosyl T treatment versus delayed afterwards, as Tia says, it gives us a little bit more confidence that we can do these things concomitantly. However, it is a randomized phase 2 trial. There's no survival endpoint in this. So you can't conclusively say that there's not an interaction. We'll be presenting some data at ASCO this year looking at enzalutamide in a very, very similar sequence. And we had the opposite hypothesis, that enzalutamide would actually stimulate the immune system, because Chuck Drake had some data in the laboratory that suggested that further androgen deprivation therapy may actually be an immune stimulant. So we'll be presenting that, and again, it's a small randomized phase 2 trial. It's still, the data is still ongoing at this particular point.
So this patient actually, again, he got Xofigo and actually had a very nice result. His current status as of a couple months ago, his PSA is still relatively low at 2.98. And actually when they did a follow-up sodium fluoride PET, he actually showed some increased sclerosis, but certainly no new lesions, and he's had a resolution of his adenopathy, and he remains fairly functional at ECOG status of 0 and currently not taking any analgesics. We tend to follow these people in our clinic, PSA, alk phos, testosterone, LDH every 3 months, scans every 6 months.
Raoul, what's your approach? Do you still like to use denosumab when you're using RAD223? Think there's any benefit during that 6-month period, or
well,
not necessary?
I don't, obviously Alcimco was accrued and Xgeva was not available. We have been very active in our clinic and getting everybody on with bone mets, using bone targeted therapy. We still continue it.
Well, this question comes up a lot because, radium is bone targeted, and as are denosumab and zoledronic acid. But if you look in the Alcimca trial, they did forest plots of patients who, were and were not on Zometa, or zoledronic acid. And, there was an advantage to being on the combination. So that's why I continue my bone drug, and I realized DMAB was not in that trial, but, since they seem to be similar.
Yeah, we continue. I think Matt Cooperberg. So Dendreon has this ProSeed registry, where they've got the first 2,000 patients who received commercial CYP-T. What's particularly disturbing is that I think when Cooperberg looked at this, that only about 40% of patients, even with bone mets in that registry, are receiving bone targeting therapy. So it's still a less than 50%, unfortunately, are getting concomitant bone targeting therapy, despite what NCCN is recommending.
I know.
And again, we just need to do a better job educating the physicians on the importance of bone health.
I want to just say that I think this is human nature. I don't think it's a sin of urologists per se, because don't forget, it wasn't that long ago when only 40% of patients were receiving docetaxel. So,
well, the reason I think it makes sense is because I would envision the denosumab as preventing new metastatic lesions, rather than, I'm not trying to co-target the metastatic site that RAD223 is, but to prevent new metastatic sites, and bone stabilization would make sense. And so I do think it makes sense. I just wanted to bring it up because I think there's an opportunity there that's often overlooked.
Because wasn't that the case, even though 147, the Amgen 147 trial, it actually did show that there was a delay in new lesions in patients getting denosumab in the non-metastatic state, but the reason why the trial was not approved was because of the fact there was not a survival benefit, correct?
Correct.
well, and they felt that the 4 months was not sufficient enough delay to warrant approval
Of the drug.
of the drug for that indication.